Okay. So okay, Esther is now joining, but
Okay.
I hope we all get the point, because genuinely sometimes it could actually be that your one person has passed somewhere, and in this case, it's like pointing to the woman. Genuinely, it could be that could be the case, but you always have to be open-minded and give everybody the benefit of the doubt. So you let everybody repeat their genotypes using HB electrophoresis, and then you can go ahead and confirm that indeed it doesn't match up. So if the man still wants to push for a DNA test, then it's up to him. Okay.
Ekaba.
Hey, Lorena.
Okay,
Esther,
thank you, Doc.
Esther, please, are you okay? You're welcome. So, yes, one more
Yes,
thing. Your
Doc,
patients.
I'm okay.
Okay. Your patients who are SF, do you have a lot of patients who are SF? I mean, I know you can develop SF, but I didn't know the population was that wide like that. Do you have lots of SF patients?
And CC, but they are not much. No,
Yeah.
please, they are not much.
Okay. Well, yeah, there's a possibility actually. And then your patients who are SF, do they have crazy symptoms like your patients who are SS and SC?
Yes, some of them come with severe crisis and all that.
All right, okay. Because ideally the F over there is supposed to give you some sort of protection as compared to a patient who just has SS or SC. The F there, the HBF there shouldn't sickle, so that should supposed to give you some protection. Anyways, all right. So so let's complete the slide. So on investigations, I think we've talked about almost everything. So of course you need to do the test to check. So you do a sickling test and HB electrophoresis. It's good to do your full blood count, because your full blood count would always point you to the direction whether you have.
But like class.
All right, okay, I think we can go on. So your full blood count will point you to a direction whether the HB here is low or not. Okay. Then you can go ahead and as I said, you do a blood film comment as well. Especially in a case where you have hyperhemolytic crisis, you'd have to do a urine RE. It tells you a lot of what is happening. As part of your management, once you get there with the hyperhemolytic crisis, you see that the urine also is very important. Just as I was talking about the other time, whenever you're dealing with any form of hemolysis, you need to do a serial urine collection to see what you're doing. Then you have to do a blood culture. If you have a patient coming to you with fever, sickle cell, you go ahead and do a urine culture as well. Chest x-ray is very, very important, because when you have a patient who has an acute chest syndrome, the chest x-ray would show you some sort of changes there, and that will point you to the direction of an acute chest syndrome. Okay. So complications, you could have a sickle cell patient who looks very, very small, so stunted growth because of delayed growth and physical maturation. They could also come in with a limp, just like as Esther said. So usually they have what we call a vascular necrosis of the hip and shoulder. They could also be coming in with infection, so osteomyelitis. They could be having recurrent infections, heart problems, and all that. Because their HB is low, people tend to give them lots of iron, and that can lead to iron overload. Excess iron can actually cause the heart to fail. So we need to be more careful. The anemia itself is a cause for heart failure. And on top of that, excess iron will deposit in your myocardium and then cause cardiomyopathy as well. They could have strokes, okay? Once you have the sickling cell blocking the cerebral circulation, you could have a stroke developing. they develop a lot of stones as well, what we call a specific type of gallstone called pigment stones. Okay, there are two main type of gallstones. We have cholesterol and pigment stones. Surgery will tell you, but in sickle cell, they tend to have the darker pigment stone formation. And because of poor perfusion to vital organs, you could also have inflammation or nephritis developing because of poor perfusion to the kidneys. Then they sometimes have priapism as well, because once they develop the cells sickle, they make circulation very, very slow. So in the penis, they cause flow, a reduced flow in terms of circulation, and this causes a stagnation or pooling of blood in the penis, and hence they tend to develop a very, very painful erection. Then they can also have problems with their retina as well. So finishing up, we'll take a look at the management. And even when you are asleep and then they call you and tell you to manage a sickle cell patient, there are some things that you should be able to recite right there, even in your dreams. Okay, so pain management is very, very essential. You have to make sure your sickle cell patient doesn't have pain, because pain makes crisis worse. Okay, it's like a vicious cycle. Patient has crisis and then it's in pain. Then the more pain, patients start getting worse because more crisis. So pain management calms down the patient. Okay. Remember, pain is a stressful condition, so it can trigger a crisis. So pain management. So we do a combination of pain relief until they get okay in terms of pain control. So you can give them some paracetamol, can combine with NSAIDs like diclofenac if they are not allergic to that. Best form of pain medications, the opioids, they really work. So you can give your tramadol or you can give your pethidine, controls the pain well. But sometimes you need to do a cocktail for the patient. You need to combine pain medications, and combination doesn't mean you should give your patients pethidine and morphine and tramadol at the same time. You kill your patients, because all those three medications you are giving are basically opioids. Okay, so you have to mix. Paracetamol will work in a different direction. The NSAIDs will work in a different direction. The opioids will work in a different direction. That's how you combine pain relief. The next thing is your fluid therapy. You always have to make sure you are giving your patient enough fluids. Okay, so we'd say that if you are giving a normal patient maybe a certain standard of fluid, your sickle cell patient should have about 1.5 times that standard of fluid. So if a normal patient is taking about 3 liters in 24 hours, your sickle cell patient should be taking about 4.5 liters in 24 hours. Okay, so their fluid therapy, we multiply the usual by 1.5 whenever you are dealing with a sickle cell, because we need to expand circulation. We need to help the blood to flow well. So giving your fluids is very, very, very essential. And then oxygen supplementation as well, especially if your patient is breathless. Okay, you are thinking of an acute chest syndrome, you always have to make sure that you are putting the patient on oxygen. And of course, you are checking your SpO2 to make this assessment. Okay. And yesterday, someone raised a question about giving anti-malarials in sickle cell patients, even when the test is negative. The thing is that you look at most standards of treatment, they'll tell you treat infections with antibiotics and anti-malarials. Because sometimes you would manage and then you are just giving fluids, malaria test is negative, you are giving fluids and painkiller, and then your patient is still feeling unwell, and now your patient develops a fever. Okay, every specialist will tell you to go ahead and then give your anti-malarial medication, because malaria is more common in our environment. But this treatment standard will be different from when you go to a place where malaria is not common. In Europe, if a patient has sickle cell disease and comes, nobody would bother and say, well, let me give anti-malarials, unless probably the patient has a travel history, has come to Africa and gone back, or maybe tested positive for malaria. Okay. And as part of your management to prevent acute chest syndrome, as I said, if your patient has vaso-occlusive crisis, you want to prevent acute chest syndrome, you always have to try as much as possible to put your patient on an anticoagulant. Okay, so we do prophylactic anticoagulation for them. So remember our DVT and our PE and all that. Prophylactic anticoagulation, you are giving enoxaparin, in quotes, clexane, or dalteparin, in quotes, fragment. These are low molecular weight heparins. You are putting your patient on that. If your patient develops an acute chest syndrome, then you move from a prophylactic dose to a therapeutic dose of your anticoagulant. And your standard treatment guidelines will help you with that. Okay. As part of your OPD management, because they are susceptible to infections, the way to go is to vaccinate them against pneumococcal infections. Okay. Sometimes they put them on penicillin, oral penicillin B, as a prophylaxis against that, but vaccination is actually a way to go. So you vaccinate them. Now we have hydroxyurea we are giving our patients, and what this hydroxyurea does is it improves production of fetal hemoglobin. So it would help you make a lot of HbF. And once you are making the HbF, because it doesn't contain beta globulin chains, contains 2 alpha and 2 gamma globulin chains, you won't sickle because there's no beta globulin chain here. Okay. And then one other thing we can also do is we can transplant stem cells. If you go outside, they do stem cell transplantation to manage patients who have sickle cell. And now, because of technology, they are also using a new technology called CRISPR. Okay, CRISPR, CRISPR or Cas9. You guys should read on it. Once things go right and then they approve CRISPR use, it's actually going to change diseases and how we manage them. We might even be lucky to start managing or start curing people who have HIV with CRISPR or Cas9. So you guys should read on it. It's a very interesting area. Maybe one day when we meet in class and we have time, we'll talk about CRISPR. But it's a new form of medical technology, which they are still doing more research on. And it's basically about DNA. It cuts DNA. It's like a scissors. Okay, the whole technology is like a scissors, which will cut abnormal portions of DNA and get rid of that, and then stick other parts of the DNA together so that you have only normal portions. So once everything goes right, you can even manage disease conditions like Alzheimer's and all those things. It's an amazing technology. You guys should read on that.
So
Outside
please spell that.
CRISPR. It's an abbreviation.
Okay,
it's a long abbreviation, but read on it. It's an interesting area. So once we get there one day, we hope that things will change. Okay. It's called clustered regularly interspaced short palindromic repeats. And they used it outside, they used it to manage some case of sickle cell some time back to cut out an abnormal gene. And now the person doesn't have sickle cell. So that's how amazing it works. So yeah, I'll take questions. Time is fast spent and then we close.
Sir.
Yes.
Yeah. So my question. Jephthah. Hello.
Yes,
okay.
please.
Hello.
Okay.
Evans, hold on. Jephthah, ask your question. Jephthah, ask your question.
Okay.
Evans, hold on.
Okay, thank you very much.
Jephthah, can you position yourself well? We can hardly hear you.
My question is that gene therapy.
Yes.
I heard something about. Can you hear me now? Can you hear me? The stem cell transplant. Is that so? How has it gotten to? Because I think some time past I did a little research research on it, and then it was like they will be able to do a bone marrow transplant for newborns or children who have the sickle cell disease, and then they are going to be fine. So I don't know how that is. Is it related to the CRISPR or something?
CRISPR. So when you check the management slide 16, the last point there is stem cell transplantation. So it is done, and it's different from CRISPR. CRISPR is just a gene editing tool. Stem cell transplantation, just like what transplantation means, you are giving the person new, organs in quotes. In this case, you are giving the person a new stem cell in the bone marrow. That's stem cell transplantation. That's different from CRISPR. CRISPR means that you're actually going to edit the genetic tool. So you are looking at that part that is actually making the beta globulin chain, and you are going directly to that part to go and splice off the position 6, the abnormal, and then put a new normal there. So that's different from stem cell transplantation. But yes, some stem cell transplantation, they are doing that outside as well.
Okay, thank you very much.
You're welcome.
All right, Kwashiga, please ask your question. Chancellor.
Okay, thank you. My question is, with the fetal hemoglobin, can something be done so that it will not change into the adult one?
Yes, so that is why we have hydroxyurea. So that's why I was saying that we can give you hydroxyurea if you're a baby to keep you from making more fetal hemoglobin. As to the adults who are not on this medication and yes, so they have HbF, that's what I'm saying. In a population and in medicine, there are no absolutes. You can have people who have, we are all different beings. You expect that once you draw a Gaussian curve, you have a lot of people in the middle and then small number of people in the extremes. So you can have people who are not taking any medication whatsoever, but yes, though they haven't converted fully. But it's not the common thing. It's really rare. The common thing is that you convert once you go past, the baby stage, like past a year and 6 months. You should have adult hemoglobin. So it would definitely convert. What you can do is you can only make more of the fetal hemoglobin rather than preventing it from converting. You can rather induce the body and constantly cause the body to be making more of fetal hemoglobin. And that's where the hydroxyurea comes in.
Okay, thank you.
You're welcome.
All right.
I have a question.
Nat, hold on. McLean, please ask your question. Yoxin. Hello, Yoxin.
I'm here.
Yes, please ask your question. Or you don't have a question? Okay, Evans, please ask your question. Nat, please hold on.
Yes. My question is concerning the AS. We are saying they don't normally come out with the positive malaria, but here's the case. Maybe the person has been exposed to that, and now they are saying you should treat when it's positive. So what do you do? Maybe the person has been bitten by malaria or like have the malaria in their system, but since the test is giving us negative, and what do we do as a clinician? And my second question too is with the blood grouping.
Yeah.
As Madam Esther asked, could there be any chance where a child will not have a blood group connecting to both parents?
Okay. All right. Okay. So yeah, so that's good. So when it comes to managing malaria, the STG will tell you that do a very good malaria test, not only a rapid test kit, but do a blood film for malaria parasites and ideally manage only when the malaria test is positive. So if this AS person you think has been bitten by a mosquito, you see, not all the mosquitoes cause malaria. That's the first thing you should know. Malaria is caused by the female Anopheles mosquito. So maybe the patient has traveled somewhere and seen a mosquito bites and thinks that, oh, I have malaria, but you've done your test and it's negative, and this patient doesn't even have symptoms. Sometimes some patients come to us, no symptoms, and then they tell us, oh, doc, I have malaria, mosquito bites. Sorry, I have mosquito bites, so I think I would get malaria. But it's been like, some time past this mosquito bite and you still don't have malaria. You do a blood film for malaria parasite and it's negative. You have different types of mosquitoes. You even have, apart from the fact that when it comes to the Anopheles, you need the female to bite to cause malaria. Even under species of mosquitoes, you have different types. You have the Culex, the Aedes, the Anopheles. So you have different species of mosquitoes itself. Okay, so not all mosquito bites would lead to malaria. So you don't manage your patient because your patient has a mosquito bite for malaria. You manage because ideally your blood film for malaria parasite has picked it up and said it's positive. That is when you manage. You can only go out of your way and manage if BF is negative, if the patient is febrile and you've done all labs and it's not pointing to a bacterial infection. Okay, you are thinking, okay, there's probably a viral infection, but patient is also not getting better, then it doesn't hurt to throw in some anti-malarials. But ideally, the right thing to do is to have a BF for MPs showing positive. Then you go ahead and you test for malaria. I'm using BF for MPs because that's the proper way of testing, because the rapid test kits can sometimes fail to pick the antigen over there. Most of the rapid test kits that are found on the system are specifically made for picking Falciparum plasmodium. So you see the dynamics of malaria is very crazy. First of all, you have different types of mosquito species. Then when you go past the different types of mosquito species, now you come to male and female Anopheles. We need you to be bitten by the female Anopheles. If the female Anopheles, the male Anopheles bites you, you won't get malaria. If the female Anopheles bites you, then the next thing is the female Anopheles mosquito has bitten you. So what is the female Anopheles mosquito introducing into your system? Is it the Plasmodium falciparum? Is it the Plasmodium ovale? Is it the Plasmodium vivax? Or is it the Plasmodium malariae? There are 4 different types of Plasmodium species as well. So they are different. All these 4 can cause malaria, of course, but then the falciparum is what causes severe malaria. And most of the rapid test kits we have are directed towards falciparum malaria. So maybe if you have vivax or ovale and we use the same test kit to test, we might not pick up the antigen of the falciparum malaria, and hence your rapid test kit will come and then it will be negative. You understand? Then we'll say you don't have malaria, so go. But for all you know, you have a vivax or ovale or P malaria. But because you don't have falciparum malaria, will say you are negative. So the best thing to do is to do what? A BF for MPs. And then a BF for MPs, you do a thick film and a thin film to count and then to also identify the species. Okay. So until you've done that, just be careful when you're giving your anti-malaria. Your other question about blood groups, which is totally different from sickling genotype, but we'll touch on that. Every child's blood group should be related to the parent's blood group one way or the other. The only reason why we tend to be confused about it is because we don't know how to calculate and identify the blood groups. Okay, so someone will argue that, oh, there's a child whose father is blood group O, okay, and then mother is how should I put it? How should I put it so that it will be a bit easier? Okay, good. There's a child. There's a child who let's even put the resource part out and let's deal with the actual ABO system. So there's a child whose father is blood group B and mother is blood group B. Okay, so mother is B, father is B, but the child is O. So does it mean that the child doesn't belong to any of them, or even BB? Sometimes it might sound so scary. So let's say that the father is B mother is A, okay, but then this baby is O, does it mean that the child's the child's father is not the actual father, or the mother slept with someone else? Of course not, because we have a lot of cases like that. We have a lot of cases where the mother is different from the father and then it's different from the baby. And it's because they're trying to calculate or trying to do the usual crisscross is the problem. The catch here is, now don't be confused anymore. When you have blood group B, okay, you remember we said that it is a form of inheritance. So if you have blood group B as an individual and we say you have B, it is not only B you have B with something, okay? It's either you have BB, you as a human being has BB, or BO, okay? But then usually the B is more dominant, is dominant than the O. O will only identify itself when both parents are OO. But in the presence of something else plus O, that particular blood group will dominate. Let me simplify it. You have three major systems. You have A, B, and O. Okay. So if you say someone is blood group A, it means that the person has inherited certain genetic aspects from both parents, both mother. I mean, taking one from mother, taking one from father. So just saying the person is blood group A doesn't make it easier for you to understand. If you are blood group A, to make it easy to understand, it means you are either AA or AO. It means you either got one A from your father, one A from your mother, or you got an A from a father, O from a mother, or vice versa. Okay, so blood group A, when you are supposed to draw like the crisscross thing we do, A will move from here and join here and all that. Blood group A means you are either AA or AO. But usually when we do the test won't tell you are AA or AO. You can only know that when you go down and do a genetic study. The test will just tell you that you are blood group A. But you being blood group A, you can either be AA or AO. So imagine you are blood group A and you are AO, and your wife is blood group B. And once your wife is blood group B, or your partner is blood group B, your partner can either be BB or BO. So let's say your partner in this case is also BO, and you do the crisscross. It means some of your babies would be AB, because your A will cross with your partner's B. And some of your babies will be OO, because your O over there will cross with your partner's O. And OO means that you are blood group O. So yes, you could have a child whose blood group is different from the parent's blood group. But when you go into genetic studies, you realize that it's not that different at all. It's because the picture just told you A, but it failed to tell you this A is the AO type of A. Or the picture just said B, but it failed to tell you that this B is the BO type of B. Are you okay with that?
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Great.
I understand.
Great. Okay.
Fred, you have a question. Fred.
Okay, sir. It's about the CRISPR. Thank you. About the CRISPR.
Yeah.
I know about the CRISPR. But you know, the problem with the CRISPR is that it is just, as you said, gene editing too. But it just knock out the genes. When it knock out the genes, the problem is how to deliver the
how to get the normal one out. How to get a normal gene out.
Network is
yes.
So right now is in this in clinical phase. You're having problem with those things, but that's where the problem. Basically, the problem is. So maybe cancer it might end up. Please, but the CRISPR is very good. It just precision, just a precision medicine. It just gets where where
it is. Thank you. Yes. So yeah, right. So that's the reason why someone will say this amazing technology. So why are we still not using it? Why are we still stuck in the ages? Why are people dying from conditions. It's because, as you said, it's still undergoing trials. So it's more of a try and error. So once they get it right, so as it stands now, they haven't legalized it to be used because they have to put a lot of things down because a lot of issues will come in. Someone can just get up and say that you can have an African or a Black person getting up. He'll come and see me. I'll be the biologist. I'll be using CRISPR. Then they'll come and they'll tell me that, oh, I am Black, but I want my baby to have blue eyes. Those are ethical issues. And with CRISPR, you can do all that. Someone can say that I want to do IVF, but I want my baby to be enhanced. I want my baby to be very strong. You only have to look for the gene for, strength and then just manipulate it. So we see that in movies, but that is what is actually happening now. So for them to approve it, they have to only approve it for the right thing. Exactly, not to make anybody superhuman over someone else. Recently, a Chinese that they sent to jail used CRISPR to do IVF. You know that story. Exactly. And someone can say he did the right thing because their parents had HIV and they didn't want their children to have HIV. They used CRISPR, they did IVF, and the kids didn't have HIV. But now they've arrested him and he's not going to practice. He's not going to practice as a scientist anymore. Okay, so it's all because of the ethical issues. But once they get it right, we're hoping that medicine will change.
Doc.
Yes, please.
It won the 2020 Nobel Prize.
Yes, that's true. It won a Nobel Prize award. Well done. You know your current affairs.
Franklin, you have your question now.
Yes.
Okay, please.
Yes, please, Mapping. Yes.
Yes, I want to ask with the stem cell transplant. Yes, does it automatically solve the problem? And if it does, how long does it solve it? Is it going to be for some time or is it going to be forever till the person dies?
So ideally, transplants are supposed to last forever, unless you have a complication where probably your body rejects the transplant. So usually once we transplant, you will give you some immunosuppressives to keep it working. So ideally when you do a stem cell transplant, it's supposed to be a permanent thing because you've basically changed your stem cell. Stem cell is like the main cell that will split to produce all other cells. Once you do a stem cell transplant, we expect that it should be forever. So we just hope you don't have what we call a graft versus host disease, meaning that wherever you are taking it from, your body reacts to it because it's like foreign, it's coming from someone else. So if you don't have a graft versus host disease, then you're actually in the money. You should be fine.
Oh, okay. And again, doing that, can it be done for aged people around the age of 65 upwards?
Okay, so it depends. You always have to look at quality of life. If you have a patient who is sickle cell and has managed to take good care of himself, because most of the time the lifespan is reduced, but now if they take that medication, they're able to live long. Managed to look after himself and gotten to 65. You have to weigh the risk of surgery to the benefits. Why would you want to? The question will be, why would you want to do a stem cell transplant for this patient? It's not like the patient is going to live for another 60 years. So on the balance of things, medically, we would say that one, maybe you are doing it because you want to take money from the patient, because you can just counsel the patient. Patients will save a lot of money, still continue doing whatever he's done to get to that point. Okay. But that, because surgery comes with other stress. So you go and do a stem cell transplant and the patient dies during the process. People won't forgive, they'll bash you, they'll say you did it because of the money. So you just have to risk certain things. Whatever your treatment you want to give to your patient, it should be better in the long run than you not doing anything. You get it? The treatment should be advantageous to the patient. It shouldn't cause any harm. Remember your medical ethics, do no harm. So always think about that first.
Okay.
So I think so we can wrap up. So because time is far gone. So basically, I would want you to just read through the slides. As I always say, it's simplified, but I try to put everything together here. But it should also guide you to do extra reading so that they can ask more questions when we meet. So I'll communicate with Nick and Thomas. We'll try and organize another session. I would want us to discuss meningitis and then probably one more topic, and then on Zoom, and then we'll do a face-to-face lecture for each of the classes to discuss probably liver disease. Then we break for revision and prepare for exams. Okay. So within the week, we'll have one more Zoom lecture, and then during the week, regular students, I'll try and meet you. Weekends, I'll try and meet you over the weekend so that we finish up this coming week. I mean, it's Sunday, so we finish up this week, and then you can start preparing for exams. Okay.
Okay, sir.
All right.
Thank you.
You're welcome. So,
Thank you very much.
yeah.
Thank
So
you, Doc.
yes, you're welcome. Thanks a lot for making the class also a success. I'm very grateful. I mean, I know the time is odd, but holiday, we are in class. I'm sorry, but we had to do it. So I'm grateful. So let's all enjoy our
You're
evening.
welcome, Doc.
Okay.
Grateful to
Same to you, Doc.
Grateful.
Bye.
Thank you.
Thank you.
Okay. Bye.
All right.
Bye.
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 Bye.